Hello, I'm Peter Leo. I'm a clinical assistant professor of dermatology and pediatrics at Northwestern University Feinberg School of Medicine in Chicago, Illinois. And this is Advances in Biological Therapies for Atopic Dermatitis in Adults and Children. This has been supported by an independent educational grant from Leo Pharmaceuticals Incorporated. Our learning objectives today are to appraise the differential diagnosis of rashes that share the common characteristics of mild, moderate, and severe atopic dermatitis to guide treatment and referral strategies, to select optimal strategy and compare the efficacy and safety of interleukin 4, 13, 31 monoclonal antibodies in adult and pediatric patients with atopic dermatitis. Let's begin with the first portion, which is pathophysiology and diagnosis of atopic dermatitis. These are my disclosures. And of course, we understand that atopic dermatitis is an incredibly common chronic inflammatory condition. It affects a huge number of people, up to 20% of children, and maybe as high as even 10% of adults, depending on where you ask the question and how you ask it. No matter how you define it, though, there is massive suffering for not only the patient, but also the family, the community, the schools, work, and even for clinicians managing this disease. It really takes a toll on everybody. This is a picture from a textbook in 1961 that really beautifully illustrates the idea that atopic dermatitis equals misery, lots of suffering. Look at this poor patient here. And one of the things that's both disheartening a little bit, but also encouraging in some ways, is that in these 50 plus years since this figure was first published, we haven't moved that far from it. But in other ways, we have. We understand better about the causes that underpin this disease. So here we see a beautiful figure from Pillsbury, Kligman, and Shelley back in 1961. Originally, it was even produced earlier. This was from a 1961 reprint where they have atopic dermatitis at the center of this maelstrom of different factors. The dog chasing his tail is the itch-scratch cycle, the concept of sweat retention, bacterial infection, contactants, antigen, antibody reactions, of course, xerosis or dryness. And then at the top, we see a really important thing, the push and pull of the psyche. And I think that's really important and is often forgotten. Fast forward many decades, and we have a fairly similar understanding of the disease. I think they were quite ahead of their time in a lot of ways. They were visionaries, but we've been able to fill in a lot of the blanks. We now have many names for some of the different factors and connections between these pathogenic factors. So we understand that there are Th2 cells. We understand the role now of some of the cytokines like IL-4, IL-13, IL-31, the master itch cytokine, IL-33, and so on. But part of the problem remains, and this is from a beautiful figure originally published way back in 2013 from Howell Williams, but again, it's still prescient and quite true. The idea that the understanding of this disease is really imbalanced. And I like this concept of the listing tree of science, that it really speaks to the fact that we know many of these details. We know about the cell types. We know about the different cytokines. We understand about some of the lipids in the skin. But when we try to translate it to clinical questions like, can it be prevented? What causes it? How common is it really? Well, there we have a lot of unanswered questions. But we're getting there. I think we're beginning to close this therapeutic gap and help this tree straighten up a little bit. And finally, we're on the precipice of some big leaps, both in understanding the disease, but also in treatment, as we're going to hear about in a minute. The best way to think about this condition, I think, is summarized with this beautiful figure from 2018. And I love this because it brings in all of the pathogenic factors that we understand and puts them into a very important arrangement. This is a vicious cycle. And we can see no matter where you begin on this inflammatory loop, you basically bring all of the factors into play. So you may begin, let's start at the top at the 12 o'clock position. You may begin with a barrier deficiency. And certainly we know that some patients are born with skin barrier deficiency, maybe filaggrin gene mutation, for example. So if we start there, we can move in a counterclockwise fashion. And we can see that that can result in microbiome disruption. So the microbiota, which is so important and an important part of our skin, can become disrupted. This can allow for overgrowth of things like Staphylococcus aureus that then release a whole bunch of different toxins, including things like delta toxin, which not only drive inflammation, but you see it actually feeds back again directly into further damaging the barrier. So we already have a loop started. But that loop even continues where we see now the inflammatory mediators released by the immune cells that have been called to this area. They're driving not only direct itch and more inflammation feeding back onto themselves, but because the sensation of itch makes people want to scratch, when they scratch, bam, we're back at the 12 o'clock position, more skin barrier damage. So the most important thing, I think, is that we now understand that no matter where you begin in this vicious cycle, you will bring all of these factors involved. And I think that's why it's such a complex disease to treat. Now, one of the things that makes it even more confusing is that it probably is not one disease. It really is a number of ways to get into that vicious cycle with that final common pathway where all of those are involved. But we are now understanding more than ever before that there are different subtypes. Now, some of these are phenotypes that we can see clinically. Others are endotypes that require biomarkers, some of which we're just beginning to learn about. And I'm hopeful that one day, not only will we be able to guide patients and understand not only what the course of the disease may be, but it'll also help us to select appropriate therapies, not just which is the best therapy for that patient in terms of efficacy, however, but also how can we minimize the potential for side effects. All of these are really important considerations. And just a quick tour through some of the work that's being done to give us a sense, there are some beautiful reports of looking at different time courses of the disease. So in other words, patients that develop it very early in life, but then have persistent disease, patients who develop it later in life and then seems to resolve. These different groups can be looked at without looking at their skin at all. We're not looking at the submorphology. We're not even looking at many demographics here. We're just looking at the time course of disease. And this already allows us to separate at least 6 different classes here that we can see, 6 different groups. And then when they go back, they're able to show that, look, this early onset persistent disease is more associated with the male sex. The one where it is late onset resolving, that seems to have a strong familial component here, showing it with the double helix DNA. Pulmonary disease, in particular asthma, is more associated with the mid onset resolving, and so on. So we can do this and start to separate these groups out, which at this point doesn't mean much from a therapy standpoint, but certainly already we can see that there's potential for being able to give some guidance about prognosis. If you have the early resolving, that's very good. If you have the persistent disease, that's not so good. And we need to be able to distinguish. But right now, we're not really able to reliably. Now, looking at some of the different molecular approaches that have looked into this, we can see that there are important differences, both in terms of the control groups that we're looking at and even normal appearing skin. And this is something fascinating. Normal appearing skin in patients with atopic dermatitis is not healthy control. It's really not normal skin in a different patient. So we're trying to separate all of these factors and look at some of the different breakdown in terms of both immune system issues and in terms of the skin barrier dysfunction. And this is a beautiful paper just from a couple of years ago, summarizing a lot of that work and putting it onto a very nice chart where we can see both, again, clinical phenotypes, we can see the immune polarization, and then the epidermal barrier changes compared across several different groups: European American AD, Asian AD, African American AD, pediatric AD, and then psoriasis, just to give us something completely different. So we can see there are significant differences through these. Now, obviously, there's a lot of variability within each group. These are not hard and fast, but it's important because it gives us the first entry into thinking about personalized precision medicine, right? That's where we really want to go. We don't necessarily just want it for a group. We want to be able to look at a given patient, especially if somebody doesn't cleanly fit into one of these categories, which increasingly patients do not. It's so nice to be able to say, okay, in your case, this is what we're seeing, and therefore we can figure out what's going on. Now, let's add on top of that the complexity that this disease is very, very dynamic. So we often see different patterns of disease over time. Some people have very spiky disease. They get a big flare up, then they get better, big flare up, they get better. Others have more of a seasonal flare, and they're good for the rest of the year, maybe winter. Some people it's summer with the heat and humidity. Other people are just kind of bad all of the time. So we're really trying to understand this more of an individual pattern as opposed to more global patterns as well, because that also can inform us a little bit about what's going on and what some of the triggering events may be. And of course, ultimately, what kind of a therapeutic protocol we need to design for those patients. Very early on, now we are beginning to be able to distinguish using things as simple as tape stripping, so non-invasive ways to distinguish between atopic dermatitis and psoriasis, which sounds very crude to clinicians. We can usually do that in the blink of an eye, but it's very important because it suggests that if this is the beginning, in a few years, we may be able to, again, non-invasively be able to distinguish. And what are they looking at with those tape strips? Well, this is the heat maps that they're generating. So for example, they're able to show an atopic dermatitis, a lot of those Th2 biomarkers that are hot, they're upregulated. And in psoriasis, a lot of the Th1, Th17 biomarkers. And you can see, I mean, if I just showed you those, you'd say, oh, these are clearly different. And that's the beginning of understanding a lot more with p-values that are, less than 0.001. So very exciting times. Now, that's eczema versus psoriasis, or atopic dermatitis versus psoriasis. But there are a number of other mimics that we have to consider when we look at this disease. Most of the time, I feel very lucky that there's not a big diagnostic dilemma for my patients. We usually know it's atopic dermatitis. We see a lot of it. It's very common. But that doesn't mean it always is. And some of the things we have to think about are things like seborrheic dermatitis, irritant or allergic contact dermatitis, dermatophyte infection, so ringworm, but it can be more widespread, scabies, Wiskott-Aldrich and hyper IgE syndrome. Those can actually masquerade. Same with Netherton's, can look very much like atopic dermatitis. In our adults, we're also thinking about our cutaneous T-cell lymphoma. Of course, certain vitamin deficiencies and mineral deficiencies can result in a very eczematous presentation as well. So there is a lot of things that we have to consider, especially if somebody's not doing well. It's a little easier if they respond great. I don't think you have to do the $1 million workup, but here's a patient who continues to develop atopic dermatitis-like eruption on their body, but particularly focused on the belly. What's going on here? Well, this is a beautiful case of allergic contact dermatitis, in this case to nickel. And the funniest thing was the patient vehemently denied it. She said, it never hits my belt. It never touches the belt. But it's so funny because if you look at the belt, you actually see there's scale crust on the belt. It's clearly touching the skin. And then when we got her to use non-metal belts, everything cleared up. So we had her switch to plastics. Another very similar case, again, with this nickel allergy, allergic contact dermatitis. Now, the reason I put these here is because you can see the allergic contact dermatitis pretty clearly here, but they also had eczematous lesions on their body. So what we might call that then is sort of an id reaction to the primary allergic contact dermatitis, but it can be very, very messy and difficult to separate these things. Here's an adult patient who had eczema on the buttocks for many years, lots of topical steroids. It would initially get better, but then it would flare up again. Finally, after a few biopsies, it did finally show itself to be cutaneous T-cell lymphoma. So that is one of the important mimics, especially in adults. This little baby had a lot of problems, including a large lymphatic malformation, and developed a diaper rash that wouldn't heal, then developed this eczematous eruption all over the body, but again, focused on the diaper area, almost erosive looking. This is acrodermatitis enteropathica-like eruption. She was actually zinc deficient because there was a mistake with her total parenteral nutrition. So with a few days of boosting the zinc, everything cleared up perfectly. Really wild, but very much can look like atopic dermatitis. And then, of course, we have this patient who developed these hypopigmented patches. Initially, someone said, well, maybe it's the pityriasis alba, right? The little light spots you can get in the context of atopic dermatitis. And so, I don't think so. A biopsy here helped us cinch the diagnosis of pityriasis lichenoides chronica. So there are other things we have to consider, including our friends. These are the little ova, the little scabies eggs. And here's Mama Scabies, Sarcoptes scabii ver humanus, waving at us, saying hello. So we have to be really careful because scabies, of course, makes an eczematous eruption. All of these things are very, very important, I think, when we're especially talking about a patient that has not responded. So the big breakthrough, I really feel, came with the understanding that filaggrin can be mutated in certain patients. And filaggrin is so important because it plays a number of different roles. It stands for filament aggregating protein. It's kind of a portmanteau. And what's really neat is that it plays a role in mechanical strength, but as only Mother Nature can do it, when it breaks down, it actually is the key piece of natural moisturizing factor, NMF. And that's because it's composed of these hygroscopic or water pulling amino acids. Turns out it also has regulatory effects on different enzymes. And that's what that piece about calcium dependent events means. So when you are missing filaggrin, not only do you have leaky skin because you have poor mechanical strengths and barrier issues, but you also lose some natural moisturizing factor, or all of it. And you also have problems with some of the activity of some of these proteases and enzymes that can actually chew things up. So we know that the genotype-phenotype connection for filaggrin gene mutation, the gene is actually called FLG, but it's easier just to say filaggrin. And this really connects to ichthyosis vulgaris. But a huge percentage of patients with ichthyosis vulgaris actually have these features of eczema as well. So when you do the math, it's maybe as high as 15% of eczema, you could say, or atopic dermatitis, and you notice I use those terms interchangeably, we could say is due to filaggrin mutations on a population scale. Now, this does vary a lot depending on where in the world you're at, because in some parts of the world, this is a common mutation. In other parts, it's very uncommon. But it's pretty exciting that for the first time, we can actually, if when a patient or a family says, why me? Why is this happening? We can say, this is why. It's a gene. That's a big deal. That's a huge sea change for the way we've been able to think about this disease. And there are important clinical ramifications of this. This is a beautiful paper from McAleer et al. In 2018, where they actually showed that the maturation of the skin is different. And this may explain why, for example, we often see what's called the headlight sign. The nasal tip is usually spared, but the rest of the face usually is pretty involved with atopic dermatitis. And it turns out that natural moisturizing factor levels get normalized very quickly on the nose, but take a long time on the cheeks. So finally, we can understand, aha, that's why the cheeks are so often broken down and irritated, but the nose is almost invariably okay. Another big breakthrough happened with the idea that certain cytokines, and in particular IL-4 and IL-13, which are central cytokines for atopic dermatitis, they not only drive inflammation, which they've been known to do for quite some time, but they also seem to decrease filaggrin gene expression. So people that have normal filaggrin gene, FLG, in the context of inflammation, they actually then become deficient functionally. And this is huge because this goes back to that vicious cycle. And now's that point where if you have inflammation, even in a normal host with a normal barrier, now they have an abnormal barrier. And that, of course, fuels this whole process. So this is, I think, a very important breakthrough that also explains to us why the barrier is so often involved, or I would argue is always involved, definitionally involved in atopic dermatitis. Now, to add insult to injury, many of the treatments we use, in particular our topical corticosteroids, they have a deleterious effect on the barrier as well. So we're helping and harming at the same time. You know, we're working on that inflammation, but further damaging the barrier. And this is a beautiful study, very small study, but in the British Journal of Dermatology, where they're showing that betamethasone, a corticosteroid, actually increases transepidermal water loss. In other words, the literal leakiness of the skin, water leaking out of the skin. Whereas tacrolimus, a non-steroidal calcineurin inhibitor, decreased the water loss through the skin. So this is important, and it is statistically significant here. P was 0.038. So this is important work. And I think this, to me, also shapes my understanding of how I'm going to use things like corticosteroids. They're very powerful to cool inflammation, but they can cause trouble if they're used too long. So I like to get in and out. I don't want there to be much barrier damage. I want to cool the inflammation and then ideally switch to a non-steroidal agent. This is a beautiful figure kind of putting everything together that we've talked about with the skin barrier alteration. We have some of the different cells coming in from the blood vessels into the skin. We have some of those factors, including IL-4 and IL-13, bringing everything. And then one thing we didn't specifically call out, but is that when that barrier is leaky and weak, then allergens, irritants, pathogens can all get into the skin, of course, further fueling this process. So either way, the problem is here to stay. Chicken or egg, it does not matter. This is important factors for atopic dermatitis. And my hope is that one of the things we can do is we can work to restore that skin barrier. And we know that moisturization can help both with atopic dermatitis, but maybe because some of those allergens and irritants can get through the skin, maybe by restoring the skin barrier, we can actually prevent some of the development of things like food allergies, because now the thinking is that part of the way that that can happen is via the skin, transcutaneous or epicutaneous sensitization to foods or other allergens through the skin. Really amazing. Now, just a couple of moments more I want to talk about and just hover for a minute over bacterial diversity in the microbiome. We now understand that there is a correlation between bacterial diversity of the skin and disease flare-ups. So, and you can see it here, it's a negative correlation. So as diversity goes down, as measured by the Shannon index, we actually see atopic dermatitis getting worse. So more diversity is actually protective and is a good sign. Less diversity is a bad sign. And again, usually means less diversity because there's more staph, which is dominant. Why is staph bad? Well, it does a lot of things that can cause trouble, including releasing these factors like delta toxin that can actually drive inflammation and damage the barrier directly. So these are some studies demonstrating that. And that's not all it makes. It's not just delta toxin. There's also alpha toxin, which damages cell membranes. There are things like enterotoxins, protein A, fibronectin binding proteins, clumping factor B. So staph is a bad actor on the skin, causing a lot of trouble. And that's why I think there's so much push to understand it. In the very, very exciting paper from 2012 by Heidi Kong and others at the National Institutes for Health, they made a bold assertion, and I think they were right on, that staph is actually one of the key drivers of atopic dermatitis. Up until this point, I think we really had felt that it was more of a bystander or an opportunist, but now we understand it's a major driving event. Now, the nerve endings, I don't want to leave them out. They're really important too. And there's more being understood about how the nerves are perceiving itch and the different factors driving itch. For example, IL-31 is a really important driver of itch right on the nerve endings, and that sends the sensation for chronic itch. Now, notably, if you look here, this is not necessarily depending on histamine. So we often give antihistamines, and there's a mast cell. You can see a mast cell on the screen. They're playing some role, but they're definitely not the major factor for this chronic type of itch. So we would actually say this is histamine independent itch pathways. And that's why people often say, why do you take them off the antihistamine? It's because it doesn't do anything for most for atopic dermatitis patients. Now, are there some patients where it helps? Yes. Are there some patients who get a benefit from the soporific effect of it? Absolutely. And so if it helps people sleep a little bit, I'm okay with that for a little, but I really don't like them to be on them long term. And I really would challenge anybody who feels vehement the other way, try it, get their skin under better control and see if you can stop it. And I think the answer 9 times out of 10 is going to be, yeah, they were okay. They didn't need it anymore. Of course, there's also a huge psychobehavioral aspect to all of this disease. We could spend some time on that. And I think that's fascinating because it really does affect the brain both directly, but also the behavioral aspects are all deeply tied in. And we know there are sequelae of this disease like anxiety, depression, more sick days. And even a thing that I love, instead of absenteeism, right? Sick day would be absenteeism, but there's some people who make it to work, they make it to school, but they're not all there. So they call that presenteeism. I love that idea. And that's hard to quantify. It's like, well, you were here, you weren't really participating well, you were half asleep because you hadn't had a good night's sleep in weeks, but they were there. Now, there are a number of different assessment tools, and it's a bit beyond the scope of this talk to get into them, but they're fascinating, and there's lots of interesting ideas and many strengths and limitations to them. One of the biggest limitations has been that they're often calibrated on lighter skin tones. So I'm very proud that I was part of a group to build out the PO SCORAD, the patient-oriented SCORAD, to make at least 3 different groups now. We have the original lighter skinned group. We have sort of a mid-tone group with maybe Asian and patients with middle skin tones, Mediterranean, Latin American tones, and then darker skin types. Obviously, this is not going to include everybody yet, but it's a start. And we're very happy that this is where things are hopefully going to make it easier for patients and clinicians to see some of the important differences in skin types so that they can actually give a proper diagnosis. And of course, one of the most common ones we use is called the IGA score, Investigator Global Assessment. And this one is easy for all of us to do in clinic. And I would encourage everybody to at least think about doing it. It's literally just giving a number, 0, 1, 2, 3, or 4. Are they clear, almost clear, mild, moderate, or severe? Easy peasy. So 0, 1, 2, 3, and 4, 5-point scale. If you can get into the habit of that, that is very powerful. Or if you're feeling very ambitious, you could even use something like this, the Patient-Oriented Eczema Measure or POEM score. It's 7 questions. It's been validated. It's free to download, and you can give it to your patients. It takes them, I kid you not, a minute and a half at most. You can have them do it while you're waiting they're waiting for you to come in. You can have them do it while you're not even in the room. And then you can review it with them. And it's so powerful. And it goes from 0 to 28. And there's actually some numbers to help people know where they're at. But even if you just kind of track it over time, these are such good questions to ask those patients. So in sum, I think we now understand this is a complex disease that has both inflammation and barrier damage. No matter where you start, other pieces are involved, including the microbiome, the itch, and those nerve endings, as well as neurobehavioral pieces. All of this is playing a role. So there's a lot here that we have to think about, but I'm really excited because we are finally learning some new approaches to meeting the needs of each one of these patients, given the complexity and heterogeneity of this disease. Thank you. Now I'd like to move into our second portion, which is new and emerging treatments for atopic dermatitis. These are my disclosures. And I'd like to begin with a quote from L. Duncan Bulkley. This is from 1881. Quote, eczema has been rightly called the keystone of dermatology, and he who fully masters its management is not only skilled in regard to treating one of the most common and distressing of all cutaneous diseases, but has acquired a knowledge of the principles of dermatologic practice, which will assist in the treatment of many, if not all, other maladies of the skin. Unquote. Pretty powerful, I think. There are three major hurdles that we have to clear when we're treating atopic dermatitis. And I really focus on these a lot. And I sort of talk about these with my patients directly. We have to get people clear. We have to keep them clear safely. And then they have to be able to keep it up. All three of those have to go well for us to get where we want to go to the end of this race. And there are many, many obstacles that get in the way. Sometimes these hurdles seem 100 feet tall. One of the most interesting things for me has been looking at different individual patterns of disease. And some patients have these spiky flare-ups where every few weeks they have a terrible flare and then they're better. Others have more of a seasonal flare. Others seem to just be bad all the time. There are two that I want to point out. The first one is in the upper right-hand corner of the slide, where we see this, what I call the escalating pattern. It's ramping up. That's a very worrisome pattern. I don't want to see that. When I do, we need to call a timeout, because that to me is a sign that we're not treating it well or potentially overusing corticosteroids, be it systemically or topically, which can lead to this kind of rebound, spiky rebound flare. The one we want is the one in the middle. Upper middle. This is the one where I call this a damping pattern of disease. We're getting it better, better, better over time. And indeed, this comports perfectly with the beautiful guideline document from the Asia Pacific guidelines back in 2013, where they talked about this exact thing being our treatment goal, to get those flare-ups lower intensity and with greater intervals between them. So that's how we get towards good control. But it's often not just stopping it, it's going down this damping pattern. Now, we know all these different factors contributing, and I'm happy to say that we now have ways of addressing almost every single aspect, from the leaky skin barrier to some of the inflammatory effect happening to the ability for the microbiome to cause trouble. We can work on each one of these things, although we are at the very beginning, right? We're still learning. A general approach, and I just want to spend a couple of moments on this slide before we get into the new and exciting stuff. A general approach for this disease is really important. And I cannot tell you, my practice is only referral now. After many years of being pretty open, I've slowly specialized. Now I really only see referral patients, but I can't tell you, some of the patients have seen 2 or 3 good clinicians, smart physicians or physician assistants or nurse practitioners, really smart and dedicated. So I do not say this in a disparaging way. But they're often shocked when I talk about the very basic line here. And I often bring this out, I show them. And many of them say, oh, nobody ever really told me about what soap to use or how to bathe. Nobody ever talked about what kind of allergy testing I should do. Nobody ever wrote out a plan for me, right? So it's remarkable. And I'm like, really? And I think it's because part of it is a groupthink. When you see a tough patient, you automatically jump to the big stuff. But I love this because it really reminds us, at the very base, we have to make sure we do some education. We want to make sure we're talking about good moisturization, gentle bathing, and avoiding those allergens or irritants that we know are important. And that can be from specific things that we know they're allergic to, but also to non-specific things like harsh soaps and wool and getting sweaty and hot and not taking that, taking care to remove the sweat in a quick manner, because we know all of these things can be triggers. For a lot of people, just doing that will be enough. Honest to goodness, there are people with mild enough disease, or maybe on the precipice of atopic dermatitis. That's all they need. But even for the most severe patients, I think if we're not doing this, I think it's much, much harder to manage them. So I like to start with that baseline and go from there. So the next step up on this beautiful therapeutic ladder or staircase is being reactive with a topical, usually a topical steroid. Why do we use topical steroid? Well, they're extremely accessible. They're extremely reliable. And when used correctly, they're both incredibly safe and incredibly tolerable. And I cannot say that about everything else. So we see, for example, they put, depending on other local cofactors, we could use a topical calcineurin inhibitor. So in the United States, pimecrolimus is approved for mild to moderate atopic dermatitis in patients ages 2 and up. So that could be reasonable. We also now, not on this one, because this is, it doesn't really bring it in on this particular thing, although it did come out after it was released and approved, is crisaborole. Crisaborole is approved for mild to moderate atopic dermatitis, now down to 3 months of age in the United States. So that's pretty exciting. So you could use those. But the difference is that both the calcineurin inhibitors as a class, tacrolimus, pimecrolimus, and crisaborole, not only are they not as accessible because crisaborole's brand name only. The TCIs now both have generics, but I find they're both very expensive, especially compared to a topical steroid. You can get triamcinolone for $4 or $5. These are at least $100, and they're in Chicago area. They're a couple $100. And insurance may not always help. So that's the other issue. And they also, both the TCIs and crisaborole, have the potential for stinging and burning much, much higher than what we see with topical corticosteroids. So a lot of patients say, why do we even use them still with topical steroids? That's why. That's the truth. So we can be reactive. Okay. If you flare up, so you're obviously doing your baseline. If you flare up, we put that on for a little bit. And then when you're better, you take a break. Again, for a huge swath, maybe 30, 40% of all atopic dermatitis in the world, that may be more than enough. They're great. Maybe even higher, depending on where you're located. If it's more mild, that's going to take care of most people. So perfect. They're using it intermittently. They're safe. They're doing all their basics. Okay. What if that's not enough? Okay. There are those 3 hurdles. Maybe that's not enough to even get them clear. First hurdle. Maybe, much more commonly in my practice, I can get them clear, but they don't stay clear safely. They tell me as soon as I stop the steroid, doc, I flare right back up. So you said not to use it all the time, but I'm needing it every single day pretty much, or at least, 20 days out of the month. I can get a couple days off here and there, but that's it. So that's not safe. In that case, then we can start using, as we see here in that third rung, moderate SCORAD or recurrent eczema, we can progress to using something in a proactive way. And this is really powerful. So they could use their topical steroid for a little bit. When they're better, instead of going just back to moisturizers, they go back to using something like topical tacrolimus, pimecrolimus, or potentially even crisaborole. It's actually even been studied with milder topical steroids. And all of these have been shown that if we proactively treat trouble spots, usually it's done 2 or 3 times a week. So I often tell people, just do it on the weekends or do it like a Wednesday and a Saturday or something, whatever works better for their schedule. That actually can be preventative. Now, it takes a lot of work. It takes some counseling, and it can be very difficult to do, but it's powerful. And then what if that's not enough? They didn't get clear. They didn't stay clear safely. Then we really go to that next level, the persistent eczema, where we say, okay, do we need to think about things like light therapy? Do we need to think about things like Dupilumab, conventional immunosuppressant, or even hospitalization? So obviously, this is something that slides, and it's definitely more that we can use it on an individual basis for each patient. It's not hard and fast rules, but I think it gives us a really nice sense of the landscape of how we can think about this condition and the spectrum of the disease that we may see. Now, I mentioned an eczema action plan. This is something I do for every single patient I see, and I think it's so powerful to write out a plan. And I can't tell you how many people even get choked up. They're like, no one's ever done this for me. It doesn't have to be fancy. I just make it very simple. When you're flaring up, here's what I'd like you to do in the morning. Here's what I'd like you to do in the evening. You'll do that for several days, up to 1 week. Once you're better, here's what I'd like you to do when you're better. And you can see here, I actually have tacrolimus as my maintenance, as a proactive approach. And when they're flaring up, I'm using mometasone. I'm using a gentle cleanser. I'm having them even do some wet wraps. And this is a very, very powerful thing because they feel empowered. They know what to do. And they also have a sense of what order of operations and where things go. So it really is a powerful tool. And it only takes a couple of minutes, honest to goodness. Now, the International Eczema Council panel made some recommendations about when to go up to that systemic therapy. And this is fascinating. So if aggressive topical therapy is not achieving adequate control of the disease given, and we know we've done adequate education, we know we've addressed infection, because that can be a trick. We know that it's affecting their quality of life. When we made sure we thought about those differential diagnoses like cutaneous T-cell lymphoma or allergic contact dermatitis, and if we've at least considered phototherapy. Phototherapy is one of my favorite modalities. It's just clunky because a lot of patients now, especially, they come from far away to see me, so it's very difficult to coordinate it. Many people live in more rural environments where they don't have access to it. And I just want to take one moment to talk about prednisone. We see here a deal with the devil. What about prednisone or intramuscular triamcinolone or prednisolone, any of those? Well, the truth is we try to avoid it pretty much at all costs with this condition. And I would argue with any chronic inflammatory condition, we really ought to be trying to avoid systemic corticosteroids. And there are actually been some really nice papers just in this past year about the exposure to corticosteroids bursts, just the bursts in kids, and they were able to show some of the adverse outcomes, everything from a hugely increased risk of GI bleeding, sepsis, pneumonia, really interesting. So I think this is important that we're careful about these and we really try to use them when we're up against a wall. We don't want to keep going back to this. And I like the way they summarized it from the paper. Quote, treatment with corticosteroid bursts is associated with a 1.4 to 2.2 fold increase in GI bleeding, sepsis, and pneumonia within the first month after initiation of corticosteroid therapy among children. Clinicians should be aware of these rare but potentially serious adverse events associated with the use of corticosteroid bursts for children, particularly during the first month after corticosteroid initiation, unquote. So what do we do instead? Well, we have a number of systemic treatment options. Now, right now, Dupilumab is the only one that's technically FDA approved for atopic dermatitis. All the other ones are off-label: cyclosporin, methotrexate, mycophenolate, azathioprine. And I will tell you that, especially with the pandemic, we've really tried to not start people on broad-spectrum immunosuppressants since this has been going on. And I still do. I have some patients that I have no choice, but I really don't feel good about it because we know that you're at a higher risk of infection with those. Dupilumab is kind of a breakthrough because it came out in March of 2017 as a fully human monoclonal antibody that binds to the IL-4 receptor alpha, and that blocks signaling of both IL-4 and IL-13. They share that receptor subunit. It is approved now down to age 6 years. It was initially approved for adults, then it got an adolescent indication, now down to 6. It's injected subcutaneously by the patient every 2 to 4 weeks, depending on their weight. And this is kind of a summary slide of the 3 different cohorts: the adult data, the adolescent data, and then the pediatric data. Really shows nice efficacy in all 3 age groups. And really importantly, reassuring safety profile, again, in all 3 age groups, including the littlest age groups here, the 6 to 12-year-old age group that I pointed out here. The biggest issues we see with it: conjunctivitis can happen to maybe on the order of 10% in some cohorts, maybe even higher of patients. That's one of the biggest things we're seeing. But actually, it seems like infection risk overall is numerically lower in people taking Dupilumab, which is really neat. So that does seem to be protective. And what we understand now is that with vaccination and COVID, it does not seem to affect the risk, which is really important as well. Obviously, that's something we're still learning about, but thus far, the data that we have. There are a number of other targets that have been identified now, and it's about to get very interesting in the world of atopic dermatitis because that was a few years ago now, in 2017, but a number of different things, including targeting IL-13 directly, targeting IL-31 directly, targeting IgE. All these different things are now potential targets. So there's been some movement. But one of the most exciting things that just got approved in the month of October, so very, very recently, was the first topical JAK inhibitor, Janus kinase inhibitor, called ruxolitinib. It has been approved as a 1.5% cream and is now approved in the US, which is great. Kids 12 years and older. And this is exciting. So what they found was minimal application site pain in the phase 3 study, no treatment-related adverse events, and all of the treatment-associated events were mild to moderate, and itch reduction within the first day of use. And we can see here they're showing us the vehicle versus a 0.75% concentration versus the one that actually has been approved, the 1.5%. And we can see that nice dose response curve, both in getting people clear or almost clear, the IGA score of 0 to 1, as well as itch and the EASI-75. Now, there was a neat kind of a comparison between ruxolitinib and triamcinolone cream, and kind of neat because we can see here, I've spliced this together. I just want to let you know, I did such a good job. You can't see it as well as you can see it blown up on my screen, but this is a splice. There were some other groups, but I just brought them together. I didn't change anything. I just cut it, brought it. But you can see the vehicle, then the triamcinolone, and then we can see the ruxolitinib cream. So it seems to be on the level of, if not statistically significantly better than triamcinolone, which is pretty exciting for a non-steroidal. So that's big news just in the last few weeks. But it is the tip of the spear. We finally have a really exciting pipeline. There's so much going on in the world of atopic dermatitis. It is frankly overwhelming. And this is like my favorite world to live in. We wrote a paper just last year and it's already falling behind, but I selected a couple that were in late stage development. And these include some of the topicals, like the ruxolitinib we just talked about, that has now come out, delgocitinib, of course, topical roflumilast, topical tapinarof, some systemic small molecules. The JAK inhibitors are all hopefully coming. They've all been submitted to the FDA. We're waiting on them: upadacitinib, abrocitinib, baricitinib, and then a whole bunch of new biologic agents, including lebrikizumab and tralokinumab, IL-13 inhibitors, and nemolizumab, an IL-31 receptor inhibitor. So let's delve into a couple of these so we can see what's going on. We have delgocitinib ointment. So this is a topical pan-JAK inhibitor that broadly inhibits inflammation and a lot of cytokines, and it seems like it would be well suited for treating atopic dermatitis. It may also promote skin barrier, enhance skin barrier via production of filaggrin. So again, this may be that by blocking the IL-4 and IL-13, we said that decreases filaggrin. So if you block those, filaggrin will come up. So it stands to reason. If you calm inflammation down, the skin barrier gets better. A 4-week double-blind period. Japanese patients 2 to 15 years of age were randomized delgocitinib versus vehicle ointment, and it really did seem to do fairly well versus the vehicle. We can see the delgocitinib dropping down in terms of the change from baseline with their EASI score, so their eczema area and severity index. And we can see the vehicle kind of getting a little bit of a placebo and then popping back up. So very, very encouraging that this could be another treatment tool. I don't know how it would compare with the ruxolitinib that's out already. And that's a question that we have to figure out, how are they similar? How are they different? We don't know enough yet, but again, we can see it significantly outperforming the vehicle, both in terms of the EASI score 50% or better improved and the EASI score 75% or better improved. So really neat. Now, there's a totally new class of medicine that's being developed and hopefully will be coming out soon as another topical agent. This is a topical aryl hydrocarbon receptor ligand. And this is a very interesting pathway because it works similar to the way we think coal tar works, which is an old-fashioned treatment for both psoriasis and atopic dermatitis. It seems to both improve barrier function and be anti-inflammatory. There have been a couple of studies so far. The one that I'm pointing out here is a double-blind phase 2b study. It was a dose-finding study in adolescents and adults with moderate to severe atopic dermatitis. They actually saw significant itch reduction at 1 week. They got a lot of patients clear or almost clear with a 2-point reduction, but there was some stinging and burning. It's also being studied for psoriasis as well, which is really interesting. And it sounds like it may actually come out before it comes out for atopic derm. It might actually get an indication for psoriasis first. And the reason is it seems to decrease inflammation, decrease oxidative stress, and again, increase that skin barrier. Kind of exciting. When we look at the key cytokines that we're talking about so far, IL-4, IL-13, we see that they have their receptors, but then those receptors connect inside the cell past the transmembrane proteins in the cell. They go through the JAK-STAT system. And we can see that's the next level where we've been talking about these JAK inhibitors, including those topicals, delgocitinib and ruxolitinib, and the systemic ones like abrocitinib, upadacitinib, and baricitinib. Now, they are important messengers then. But the interesting thing about JAK is that they're used in a lot of different systems. And thusly, they're also, the inhibitors are used to treat hematologic diseases and other inflammatory diseases like arthritis. So these small molecules can actually get inside the cell. What also it means is that they can penetrate through the skin pretty easily. You can't take the biologic agents generally and put them through the skin. Dupilumab and lebrikizumab and tralokinumab, these are very big molecules and they don't go through the skin. And if you eat them, presumably they'll break down in the gut and again, won't pass through the gut lining. But the JAK inhibitors are tiny molecules, so they can penetrate quickly through the skin, which makes them amenable both to oral formulations, which we're looking at here on screen, but also to topicals. So when we look, the 3 big ones that are in late stage development, again, these have all been submitted to the FDA, and actually at least baricitinib and upadacitinib are already approved, I believe, in Europe and in Japan for atopic dermatitis. So they already have some experience in the world. And both baricitinib and upadacitinib are already out and have been out for many years for the treatment of other diseases like rheumatoid arthritis. But we can see, again, nice dose response curves in all of these. And it's very tempting when they're presented this way to just compare these numbers and say, which one's the best? But I thought it would be worth just taking one moment to think about the idea that it is really, really bad form to compare across trials. And this just came out very recently, but I love this. This is Jonathan Silverberg, Eric Simpson, April Armstrong, and others, a lot of luminaries that I really respect and admire. And they talked about some of the ideas about why, because, as long as I remember, it's like, oh, you shouldn't compare across trials, but I never understood why. And here they really, in this beautiful infographic, show us why. One of the things is that the screening approach can really affect the outcome. So they talk here, if you have a shorter washout, that could reduce the likelihood of a rescue. But if you have a longer washout, that may increase the result of a rescue. So depending on how the study was set up, you could get very different responses and results, even if you're doing the same drug, so comparing cross drugs is so dangerous. And then whether rescue is permitted or inhibited, whether what they did with those patients, if the patient got rescued, do you include them? Do you exclude them? How do you do this? And of course, the long-term extension trials becomes confusing too with rescue patients. So I think this is just important for us to meditate on before we try to compare them. And as I give that disclaimer, I'm now going to compare them. But here, we're not comparing across trials. We're comparing within a trial. So in theory, this is the way to do it, right? This is exactly how we want to do it within the trial, but it's ideally powered for it. So this is abrocitinib versus placebo or dupilumab. Now, technically, this is not a head-to-head in the normal way, but we still can do some comparisons. And what they conclude, I'm just going to quote them because I know that the real statistic wonks would say, well, you can't quite say that, but I'm just going to say what they said, which was published in the New England Journal of Medicine. Quote, the 200 milligram dose, but not the 100 milligram dose of abrocitinib was superior to dupilumab with respect to itch response at week 2. So that's something. Now, we can actually see some of the numbers here. These are what they looked like. We can see the EASI-75 response. We can see the over time. I would argue they look fairly comparable. And especially as we go further out, as we get to like 113 days, we actually see that the dupilumab group seems to sort of be in the lead. I don't know if it's statistically significant there, but it really does sort of more slowly get there. And at the end, I would argue those look fairly similar to me. So that's interesting. And again, it's quite an achievement. When we look at the itch scores, now this is looking at another JAK inhibitor. This is upadacitinib. We can see that the dupilumab group and the upadacitinib group are pretty different, and it changes pretty quickly. And then they maintain that separation. And then when we look at the EASI-75, again, there's some separation, especially early on. Now, as we get closer to week 16, they start to converge again. So here, I think we can say that there is, at least on the level, and maybe some superiority of the JAK inhibitors to dupilumab, but we have to see in larger trials and, of course, over time in our experience. That doesn't mean an individual's response. Some of the data that we saw here with abrocitinib, we can see the dose response curve for both IgA score and the EASI-75. And we can look at lebrikizumab, one of the biologic agents, anti-IL-13. And again, we see some similar dose response curves, again, that it does appear to be helpful. Tralokinumab is the other IL-13 inhibitor. And again, we see some improvement over the placebo groups. Very, very nice. Now, it turns out that lebrikizumab and tralokinumab are not identical, and neither of them is identical to dupilumab either. They're all distinct. And of course, dupilumab binds to the receptor, whereas lebri and tralo bind to IL-13, but they bind it at different points. And tralokinumab affects its ability to bind to what's called the decoy or dummy receptor, whereas lebri doesn't. What does that mean? We don't really know. There's some thought that maybe that's playing a role in feedback. So in theory, you might think that lebri might be superior because it would allow the feedback mechanism to happen. So presumably maybe down regulating it, maybe, if that's how this works. We don't know. Whereas tralo might block the feedback mechanism, meaning there could be some upregulation. It's hard to say for sure. And then nemolizumab, totally differently. This one's binding to the IL-31 receptor. Again, that's sort of the master itch cytokine, and it has been shown to significantly help with itch in atopic dermatitis, which is pretty neat. And here's that data looking at change from baseline. And this is actually sleep. So really helping with sleep significantly compared to the placebo, as you'd expect. We can see some of the side effects. These are generally well tolerated, these biologic agents. So that's reassuring. And what we really lack right now, though, is a way to think about them all from a more holistic standpoint. This is what's really stressful to me. So we just said it's hard to compare, but this is beautiful work from Alexander et al. And this was published just about 2 years ago, where they're actually showing us a number of different trials normalized so that we can get a little bit of a sense of where things might fall. And here, this is a neat one because we can see cyclosporin, we can see Dupilumab, we can see baricitinib, and all compared to placebo. We can also see Nemolizumab, an IgE blocker that didn't do so well, right? It actually failed its early trials. So it does not seem like it's going to be useful in atopic dermatitis, although of course it has other indications. One of the things we also have to figure out is we need to understand the safety profile of these as well. We have to compare them because they're not so similar, right? Cyclosporin has its set, methotrexate has its set of issues. And of course, the JAK inhibitors have black box warnings we expect that will be on there. Even the topical one, the ruxolitinib that's already out, has some significant warnings on there. And the oral ones will almost certainly require laboratory monitoring, whereas our biologic that we do have out already, Dupilumab, does not. So we're going to have a lot of work to do. And the shared decision-making with our patients is about to get really tricky because they're going to come in and say, well, which one should we do? Or how do we think about these? And the answer is, I don't know yet. But one of the things I started to do with my patients is a shared decision-making approach. And I like to use these little radar plots. I bust these radar plots out and I say, there are kind of 5 different points that we can think about. Obviously, there are many ways to skin this cat, but I think 5 that I like to keep in mind. First is the efficacy onset. How fast does it work, right? So for example, prednisone works really quickly, but mycophenolate, in this slide, we can see it says blue. It takes forever. It takes several months. So if somebody is miserable and needs help and they're falling apart and you say, well, I'll see you in February, it's like, I need something in the short term. So but again, that might not matter for every patient. That's one point on this radar plot. So how fast does it work? And then what is the maximum efficacy? So again, here, maybe the JAK inhibitors, for example, they seem to be really fast. They're going to be, I think, on the order of prednisone. Days, they're getting people better, hours sometimes. But their maximum effect also seems to be really high, although maybe Dupilumab or other biologics could meet that maximum effect over enough time. Maybe that'll be 6 months or a year. So that's important. But, we got to figure the differences out there. Then accessibility. How easy is it to get and obtain? That's huge. That doesn't just mean price. Price is much, much more, it's a much smaller factor because it could say it's $1 billion, but if the patient pays $10, well, okay. And then it could say it's only $98, but if there's no support, many patients of mine aren't going to pay $100, but that doesn't sound that ridiculous, especially for a biologic agent. So it's very complex with cost. And then of course we have safety, which is huge, but also tolerability, which is another aspect. And that often gets forgotten, especially outside of dermatology. They don't really talk about tolerability in quite the same way, perhaps, maybe like something that causes upset stomach, but we have so many pieces, and that includes cosmetic elegance. It includes stinging and burning, all these different pieces that aren't safety signals, but really can affect the uptake and the continued use of a medication. All of these play a role. So in sum, the past 50 years have been really quiet. We haven't had many new breakthroughs, but that does not seem to be predictive of what's about to happen. The next 5 or 10 years seem to be bonkers. We have so many things, over 100 new treatments that are in development. We're also on the verge of a giant leap in better understanding this disease. And of course, this is that virtuous cycle of drug development. We learn more about a disease by the drugs. We get better drugs, then we learn more about it. It keeps spiraling up. With this new understanding comes these new treatment approaches. And now we have more promise than ever before to help our patients who are miserable. I want to thank you for your attention. I hope you enjoyed it. Again, this was supported by a generous independent educational grant from Leo Pharma, and we're very grateful to them. I wish you all the best. Thank you.